to welcome you all to the London School of Hygiene and Tropical Medicine. My name is Cara Hansen. I work in the Faculty of Public Health and Policy, and I'm one of the co-editors of this series of papers for the Lancet about the private sector in health. We've got a full program. We have 4 short presentations of each of the 4 papers, and then we've invited some distinguished discussants to reflect on the papers, what they say, and further interpretations. So I think we're going to crack on. I'd first like to introduce our host for the day, Richard Portman, the editor of the Lancet, and hand the chair over to him.
Okay, thank you very much. Cara, thank you very much indeed, and to Barbara for leading the series, and to all the authors. Friday was a big day, and not just for the reasons that you're thinking that why it was a big, terrible day actually. It was a big day for another reason. That's because Barbara and I submitted a final draft of a report we've been working on for the past 3 months, looking at the evidence around whether investing in health employment, health professionals, community-based health workers and other cadres of health workers was actually good for economic growth. And it brought together a unique group of economists and health specialists to answer that question. And it's a question that's being posed by a commission that's being led by WHO, ILO and OECD, chaired by Presidents Hollande and Zuma, and that will be launched in September this year. Now, why do I mention that at the launch of this series? I mention it because Barbara and I and a whole bunch of others had to look at an array of evidence on whether health employment was a good investment for economic growth. And in all of the evidence we looked at, the most difficult area, the most controversial area, the area that brought out more passionate disagreement than any other, was the role of the private sector. The role of the private sector in health education, the role of the private sector in expanding employment for health workers. If you create a whole new, enormous cadre of health workers, who should employ them? Should it be the public sector or should it be in the private sector? What's the right mix? And in that debate, there was clearly a lot of passion, quite a bit of ideology, and actually not that much either understanding or evidence. When we started this series, which was a few years ago now, and the authors have had tremendous patience to stick with us as we've gone through various iterations of trying to understand this whole question around the private sector. When we started this process, of course, we were coming to the end of the MDG era, and we hadn't got SDG 3.8 on universal health coverage finally approved and the deal sealed, but now we do. And the series that we're going to talk about this morning couldn't have come at a more opportune and important time. To understand what the contribution of the private sector is in the health economy of countries, and indeed transnationally, in the goal of achieving universal health coverage. This series looks at 4 very important aspects of that question. It seeks, and I believe succeeds admirably, in demystifying the private sector, in dealing with some of the myths that surround the private sector, and in very provocatively inviting us to reconsider our approach to the way we think about the private sector in the delivery of health care. We've got 4 fantastic presentations lined up for you, as Cara says, and let's start off straight away with what seems like such an obvious question, and yet one riven with confusion and misunderstanding. And Maureen McIntosh is going to answer the question for us. So, what is the private sector? Maureen?
Can I just remind you, those of you who are tweeting, this is the hashtag that we're using for today.
Thanks, Cara. Thank you very much indeed, Cara, for the invitation, and Richard, for the invitation to present this. We're delighted this series is out. As Richard says, we were asked to answer the question, what is the private sector? In other words, to answer that in order to assist the understanding of private provision within health systems in lower middle income countries. And the way we did this, moving straight on since we've got 10 minutes each, this is a collective paper. The authors are Indian, Chinese, Argentinian and UK. So we were trying from the very start to get a set of multiple perspectives and concerns into the challenge of answering the question, how do you define and how do you measure the private sector? And I see it says the public sector there, so ignore that. And what we've done is it includes new analysis of secondary data, it includes some primary data, it draws on literature and searches, but it's not a systematic review, it's an argument, and it has a focused use of some qualitative evidence. And this very brief talk is in memory of a very valued colleague and fellow author who wrote the Chinese section of the paper, Dr. Hongwen Zhao, who sadly died before it came out. So this was the challenge we were trying to address. Define it and measure it as the first paper in what would then be a set of arguments about what happens next. Clearly, both definition and measurements are essential in order to understand the role of the private sector in healthcare and in order to shape effective policy towards universal health coverage. One of the things that makes it very difficult to do is the extreme heterogeneity. We originally called it wild heterogeneity. The literature is full of overlapping and competing definitions of a very complicated sector. There exists one global database, which, though flawed, is genuinely useful on the public-private split in health expenditure, but there is no equivalent database on the supply side, nor indeed is it straightforward, as we rapidly came to the conclusion, to generate definitions that allow such a database to be constructed. So in looking at definitions and measurements, essentially what we're going to argue, what we do argue in the paper, is that you can define and measure the private sector in ways that allows you to use existing data quite straightforwardly, but you can only do it if you're prepared to do it in the context of trying to understand the health system as a whole. In the end, our definition of the private sector is perhaps childishly tautological. It's the totality of privately owned institutions and of private individuals providing healthcare, including private insurers, including the for-profits, itinerant drug peddlers, all the way through the individual clinical practitioners to the corporate hospital chains, and the non-profit faith-based clinics, and so on. So what we propose in the paper, and the argument about why it works and why we did it this way is in the paper, is that we've proposed the use of 3 metrics for measuring the private sector within a mixed health system. The first is the size and pattern of the share of private finance in total health expenditure, using the WHO health expenditure database. That's relatively straightforward. The second is the share of the private sector, defined as I just have, in primary and secondary healthcare episodes. And we chose episodes rather than capacity because the number of facilities or the number of beds doesn't tell you a great deal, so we chose usage. And the third one, which was the most controversial within the group, was the extent of public sector facilities' reliance on out-of-pocket fees and charges, which we've drawn from the national health accounts and other data, and that took a lot of work. And just for the records, all the efforts that have been attempted to do this in the past have shown that metric 1 is not correlated with metrics 2 and 3. So you need them all in order to create a pattern. So essentially what we're suggesting is that you can measure in a fairly straightforward way the private sector in health systems on those 3 dimensions. The private share in spending is, if you like, the demand side. The share of private sector visits or episodes, it varies. What's actually measured from country to country is, if you like, the supply side. And the public sector percentage reliance on fees and charges is the level of commercialisation of the public sector, which influences the behaviour and nature of the private sector. And that's one of the fundamental arguments in the whole series. So what we've done in the paper, and very much hope you will read it, is we've drawn out an example initial typology of private sectors within mixed low and middle income health systems using those metrics and then using a substantial amount of other qualitative and grey literature. And these are the 5 example typologies, if you like, they're stylized facts, or economists would say, of the types of private sector that we identified using these, and then we gave them as examples. One is low and middle income countries that have an almost completely dominant private sector with a relatively deteriorated or small public sector, and we've used India and Nigeria as examples of that. One, which is discussed at more length elsewhere in the series, is where you have a relatively universalist, even if not perfect, public sector. And a private sector which effectively works by complementing that, typically further up market and of better quality. The third is where you have a high-cost, relatively high-cost private sector, which is funded by private insurance and maybe social insurance, which heads a stratified economic and social system, where the public sector is definitely for the bottom end of the economic system. The fourth is private sectors in contexts where you have a large and highly commercialized public sector. And China was our example of that 4 years ago. It's now a country undergoing reform, which nicely illustrates what it takes to row back from that kind of structure. And the fifth one is look at some very low-income countries which have stratified private sectors, which are quite reliant on small-scale, particularly shops and informal providers at the bottom end, and which we argue are shaped by public sector characteristics. These are our two more slides. I'm watching the 10 minutes. These are the key messages from our typology. The first one, you remember this was India and Nigeria, where the private sector dominates the health system. The poor in a country struggle to access fee-for-service care, generally of low quality. These are the key messages for universal health coverage. Secondly, remember this was examples of Sri Lanka and Thailand, where you have a reasonably competent and highly accessible public sector. This can generate a complementary and better quality, reasonable quality private sector, which is further up the socio-economic scale, with much better implications for universal health coverage. The third one, the high-cost private sector at the head of an economically and socially highly stratified system. Argentina and South Africa have many facets in common. What you have there is a system where the health system reinforces high levels of social inequality, and you probably get cost escalation, which makes the unification for universal health coverage really difficult. And the South African debate illustrates that nicely. As I've just said, the highly commercialized public sector in China was heavily constraining the nature of private provision a few years ago. And what we're now seeing is what it takes, and there's a reflection on that in the paper, to reform that in the direction of more universal coverage. And finally, in the low-income context, most of our examples are low-income Africa, where you have the public sector becoming more accessible in various different ways. We can see that exclusion and reliance by the poor on low-quality private providers and medicine sellers tends to reduce. So, again, with implications for universal health coverage. So, our key messages from the paper as a whole, and I hope I've made it to the 10 minutes, is that the private sector cannot be defined, measured, understood, reformed, or regulated without understanding it within the mixed health system within which it operates. The rest of the papers will talk about that. The private sector, because the private sector is strongly influenced by, and also influences the public sector. A useful typology of types of private sector for the purposes of health policy can be drawn from three metrics that employ widely accessible data, both internationally and on a country basis, but that when you're using it, you need qualitative information in each case to deepen understanding and to root policy in individual contexts. Thank you for listening.
Thanks, Maureen. We're doing great for time, so I appreciate that. So that's what it is. How does it perform? Tim Answer is going to answer that question for us.
So the second period paper in the series looks at the performance of the private sector. Now we assumed that what matters as far as the progress towards universal coverage is concerned is not the performance of individual private providers per se, but the way in which the sector as a whole and the private sector as a whole helps the system to progress towards universal health coverage. And with that lens, we focused on the evidence base around the world on this topic. So most of the existing research compares the private sector to the public sector as a whole, often without disaggregating type of provider. We were sometimes surprised about how naive sometimes the analysis is, although there is obviously also more sophisticated analysis. Most of the work compares efficiency, quality and equity as key outcomes, and most of the work pays relatively little attention to the context in which the providers operate. So what does the published evidence suggest? Well, it suggests, perhaps not very surprisingly, that the private sector, the for and non-profit private sector, is generally more responsive to consumers in terms of shorter waiting times, more time spent with doctors, etc., but less likely to conform to medical protocols and prescription guidelines. It's more likely to expend resources on unnecessary services and procedures, and it may be less financially accessible because most private services are of course paid out of pocket, but at the same time, and Maureen brings this out in their first paper, but at the same time, in a lot of countries, it's the small, less qualified providers that are offering the most accessible services to the majority of consumers. But all this evidence base we looked at, is conditioned by the individual characteristics of providers and also the system-wide context. And that affects the performance of the sector as a whole, the public and the private sector. What are these private provider characteristics? Key amongst them are whether the objectives of the provider is for profit or not for profit. Maureen's already mentioned that. The competence of staff. You find that a lot of small private providers often exhibit lower levels of competence and depend on less qualified staff and therefore generate poorer, inferior outcomes. And the size of the organisations. I think this is a really important factor. We know that hospitals, for example, need to be a minimum bed size of around 200 beds plus. Most private hospitals around the world are much smaller than that, 50 beds, 40 beds or smaller, and as a result they tend to be much less efficient and produce much less lower quality outcomes. Now, what are the system factors? Well, perhaps the most important system factor is the structure and the performance of the public sector. So you're seeing here the importance of the interaction between the sectors. A weak public sector encourages weak and hard to regulate private sector, and there's a lot of evidence around the world of that in most continents. Conversely, well-resourced provision of essential services, well-resourced provision within the public sector encourages different patterns of private sector provision, often better patterns of private sector provision. Other system factors that are clearly important from the evidence base are regulation, and we'll come to that in the next paper. But we know that bureaucratic regulation, the licensing of private providers, is more or less unsuccessful in most low and to some extent middle-income countries. It doesn't work. We need other models. Referral linkages are often weak, the links between the public and the private sector particularly, but also up and down the private sector, and the population characteristics. Okay, so what does all this mean for universal health coverage? I think it means one aspect of the literature was, although we found lots of evidence of poor practice, of weak outcomes in the way that I've already described, you also find good practice You find that some countries the private sector is producing similar clinical management of disease, even better management of disease, particularly in, and I think this is particularly interesting, the complex to diagnose diseases. And there's a body of work that suggests that private providers are much better at working out what's wrong with a patient because they're set up and the incentive structures are there to do lots of tests. Now, with simple diseases, those might be unnecessary, but with complex to diagnose diseases, they may actually be beneficial for the patients, and there's some evidence on that. And comparable costs of surgery, comparable costs of services, providing the providers are big enough. So I think what we need is system responses to improve the performance across public and private sectors. Again, a theme of this whole series. It's clear that the low quality private providers are often filling a gap left by the public sector, and so we need to fill that gap so that those unqualified providers don't fill it. We need to ensure that providers are of the size necessary to deliver quality, low-cost services. We need to create the cross-referral system. So there are a number of things that can be done at the system level, at the policy level, to ensure that the responses to the private and the provider and the public sector improves access towards universal coverage. So in conclusion, we need system responses. There is a lack of research, however, on the appropriateness, the effectiveness of different responses, because, back to the beginning, because so much of the research evidence concentrates on individual providers rather than looking at the system context as a whole. And you'd expect a researcher to say that. There's a research agenda that needs to look much more about how these system factors encourage the creation of a mix of private and public services that address the needs of universal coverage. And we need to look at some of these policy instruments around regulation, subject to the next paper, and around in other areas to see how the government can bring the optimum mix about. Thank you.
Thanks very much, Tim. So that's what it is, that's how it performs. Now what do we do about it? We can't ignore it. So Catherine is going to tell us what options we've got. Catherine, welcome.
So hello everyone, and as Richard says, we've heard a bit about the nature of the private sector, we've heard a bit about its performance, and then in this paper, Dominic Montague and I were reviewing the evidence on what we know about what we can do to address that performance. So we've heard that there are commonly a number of failures that we associate with the private healthcare sector. Maybe related to poor quality care, unsafe practices, fake drugs, or perhaps inducing unnecessary care, unnecessary diagnostics, unnecessary drugs again. It might be related to wider harms, such as the negative externalities from drug resistance, which aren't taken into account, or equity issues, perhaps leading to low coverage or impoverishing fees. So we know that some of these problems might also be found in the public sector as well as the private sector. But because of the importance of the private sector, increasingly governments, NGOs and donors have been trying to think about approaches that could address some of these issues. And we've grouped those approaches under 4 broad headings: prohibit, constrain, encourage and purchase. So with prohibit, i.e. actually prohibiting private provision or constraining its operation in some ways, this normally depends on what I've called statutory controls, and Tim was using the word bureaucratic regulation, or some kind of self-regulation. An alternative approach would, instead of to regulate, to be to try and encourage and subsidize the private sector to deliver good quality for certain services. This could be through some kind of training or social marketing or social franchising. And then finally, there's the strategic use of purchasing, either demand-side financing, perhaps through vouchers, or supply-side financing through contracting. So the objective of our paper was to review the evidence on the effectiveness and limitations of these kinds of interventions, looking specifically at private for-profit providers in low and middle-income countries. So I'm going to give you a high-level summary of what we found today, but I think while we go through this, you always have to bear in mind what Maureen described as, was it the wild heterogeneity of the private sector? So of course every conclusion is really going to depend on which system failure you're looking at, what type of provider you're thinking of, and what type of service you're trying to address. So an extreme form of regulation would be to prohibit either all private care or some specific services. And it has been tried. So an example of trying to prohibit all private for-profit practice would be the Nyeri era in Tanzania. Much more common are bans of specific services. So say many countries have a bans of abortion or certain kinds of abortion. But the stories of failure are numerous, especially in lower income countries when you have a context of high demand for a particular service and poor enforcement capacity. Often the effect is simply to drive that practice underground in some way. So while prohibiting private practice is pretty rare, having some constraint on its operation through regulation is ubiquitous. And before I get into the problems of regulation, I do want to say that we think regulation does have an impact. In most countries, we don't see a complete free-for-all where you have just, quack doctors and fake drug peddlers running amok through the country. You do see some regularization of the system. So regulation isn't pointless, but what we know is that it has a lot of implementation problems. So just to kick off, many governments are not even aware of the scale of private healthcare provision taking place. So this pie chart is showing that only 6 out of 45 sub-Saharan African countries had a comprehensive, up-to-date list of private facilities. And most lists were described as woefully incomplete and often inaccurate. And that's probably a familiar picture to many of you who've ever tried to use them as a sampling frame from your research. There are many other challenges as well. So the enforcement of regulations in those facilities is very weak. Often you have a big gap between the regulations on paper and what commonly exists in practice. And that creates a real window for corruption. So regulation often becomes a vehicle for corruption payments. There's very little evidence on how statutory regulation could be improved. With the exception of a few RCTs on pharmacies in Southeast Asia, we don't see much robust evidence. And self-regulation by professional associations, which has been so important in more high-income settings, fails to come in and fill the gap, with many of these professional associations often operating a bit more like a trade union for those professionals, rather than as a regulator. It's worth mentioning accreditation, which is a growing form of voluntary regulation, especially in some middle-income countries, examples being Thailand, Malaysia. But at the moment, this type of accreditation is only really appropriate for quite high-end facilities. It's only adapted to them or affordable to them. And the evidence on quality of accreditation is mixed. So this has led many people to try and move away from regulation and look to other approaches that try to work with the financial interests of the providers themselves while encouraging them or subsidizing them to provide certain services or making strategic purchases of those services. So these data are the results of our documentation of the number of programs we could find mentioned in the published or grey literature of this kind between 1964 and 2014. And you can see that the most common is social marketing. So this is when you use commercial marketing techniques to promote products that are considered to be of importance for public health. To make our task manageable, for social marketing, we actually only counted the condom programs. So you can see it's already over 100 programs around. And if you added in other programs, antimalarials, ITNs, for instance, that blue line would be much higher. So the second most common in red and rapidly growing is recruiting private providers into a social franchise network. So again, you're using commercial, this time franchising techniques for the social good. And this tends to be used for slightly more complex services than you could use for social marketing, so it might be antenatal care or family planning. And overall, it's reckoned there are close to 20,000 facilities now in the developing world that are enrolled in some kind of social franchise network. Turning to vouchers, there's been sporadic interest in these where you give a targeted group, it may be the poor in some way, a voucher for specific services, say immunisation or ANC, that they can use at certain affiliated providers. Or there's contracting, where you're actually contracting out part of the services that would normally be provided by the public sector. So that could be a specific service like the laboratory or dialysis, or it could be all healthcare within a specific region. So one of the disappointment when you see this number of projects is that a lot of this experience is not well documented, and there's a particular lack of robust intervention studies. But we've tried to, very briefly in this slide, summarize the evidence we look at in the paper. So we've used the number of plus signs indicates the strength of positive evidence. A question mark is pretty mixed evidence or very little evidence. And then the not applicable is for the social marketing, some of these criteria don't apply so much. So you can see that there is evidence that these types of interventions can improve coverage. Perhaps the exception there is social franchising. We know that social franchising can increase utilization of franchise facilities, less evidence that it improves coverage at a community level, and also concern that these franchise facilities are often used only by the wealthier groups. Social franchising has a more positive impact when it comes to perceived quality of care, but contracting and vouchers, less clear of an impact there. And then when we get to clinical quality of care, the impact is pretty shaky all round. So what is really clear from this is that a lot of work remains to be done to really improve this evidence base. But from what we do know, I think we can summarize a few key strengths and weaknesses of these kinds of interventions. They are potentially effective if you want to target a prioritized health service at a particular population. So say you've got a group who you really need to expand access to STI medicines, or a community with no safe access to abortion care. These types of approaches could be very useful. And from a pragmatic perspective, they allow donors to operate outside of the large, often inefficient, and sometimes corrupt national bureaucracies that exist. So they allow people to sort of get something done in a tricky situation. But they certainly have limitations when it comes to scale and scope. So apart from social marketing, they require quite intensive support and monitoring at a provider level, which can be very challenging. Vouchers and social marketing are useful for targeted services, but it's harder to imagine how they could be useful in more general health service provision. And then there are concerns about sustainability. So social marketing, social franchising and vouchers have, till now, required substantial donor subsidy. So, in sum, perhaps we can consider these strategies more as band-aids or at best bandages, potentially effective at dealing with a specific limited problem in a limited scale, but in no way a solution to the broad-based challenges of the health sector and how we're going to move towards universal coverage. So for that, I think we need to take a step back from this front line of looking at the performance of these individual providers and interventions and consider some broader questions around what we want the nature of the public-private mix to be as we move forward, which of those typologies that Maureen's shown us is our goal, if you like, and what really can governments do to shape that future. So that's it from us, and I'm going to hand over to Barbara, who will consider those system-wide issues. Thank you.
Yes, so thank you very much, Catherine. What Cara and I were doing when we drafted this last paper in the series was to try to draw the main lessons out from across the 3 papers, while also recognising that we left some gaps and trying to fill those in. So one of the things that has been a recurring theme has been this world heterogeneity. And we're stuck trying to draw across the breadth and trying to capture that while also trying to say something. And to say something about anything when there's such a variety of things that you're talking about is difficult. So the compromise that we came up was to think about 4 stylized types of private provider that we would think about. All of them embrace a very wide range of different kinds of providers within them. But these 4, the low quality, underqualified sector, and we've struggled with what the best words to describe that sector is. The not-for-profit providers that operate at large hospitals in some cases, lots of small clinics. Formally registered small to medium private practices, and the corporate commercial hospital sector. So those are the 4 things that we were trying to address here. First of all, let me look at what we had to say about that first type. Now, other papers that you've heard about it are arguing that the scale and the scope of low quality underqualified provision is primarily determined by the effectiveness of the public sector in providing accessible and reasonable quality alternative. And we heard the same argument from both the first 2 papers. And the idea is that by creating an effective, accessible, basic public service, you drive out the low-quality elements of the private sector in this process, which is sometimes called regulation by competition. And that relies on people following their self-interest and their incentives rather than depends on regulations, which, as we've heard, are difficult to enforce. A little bit more data to support that position comes in these scatter plots, which are rather more nicely done on page 31 of the actual version, if you've managed to get hold of a copy of that. What these show you is government health expenditure as a percentage of GDP on the horizontal axis, and the frequency of using one type of unqualified provider, whether it's a shop, a traditional practitioner, or a unregistered provider on the vertical axis. And it's broken down into, we've got acute respiratory infection on the top, we've got fever and diarrhea on the bottom. And the reason we've got 2 acute respiratory infections is that we're looking at both DHS data, but also MICS data, which also covers ARI. So the top right figure gives you the mix and DHS data combined. The rest are all just DHS data. We've measured the correlations, but I think what's more interesting than the correlation really is the absence of observations in the top right quadrant of these figures. What that shows us is that where governments spend a decent proportion of GDP, it looks like once you get to about 5%, the extent of use of these unqualified providers is not more than for 10% of conditions. So there's lots of other things potentially going on in these scatter plots, of course there is, but it's somewhat consistent with the arguments that are being made across the papers. Okay, moving rapidly on to not-for-profit providers. Are they the answer? Should we be relying on them? They are, of course, as already been said, themselves highly heterogeneous. They play a number of roles, from providing pretty much all urban primary healthcare in Bangladesh to providing just one small service of one type, such as family planning services is a common one in lots of countries. There's some basis for thinking that there's reasons why they might be able to perform better, so they're not so constrained by bureaucratic controls, and that might give them the flexibilities to manage staff better, for example. On the other hand, just because an organisation is labelled as not-for-profit, that doesn't mean it's necessarily altruistically motivated and only there for the public good. And there's plenty of evidence of not-for-profits behaving pretty much like for-profits, or just constrained in the same way to be unable to pursue public good any better than private providers can. And then at the extreme, we've got these sort of briefcase NGOs, which is really somebody's personal enrichment scheme. So we need to recognise strategies that have to respond to a detailed understanding, and I'm afraid we don't come up with anything more conclusive than that about the not-for-profit sector. Thirdly, formally registered small to medium private practices. These are the most common registered providers, at least. They're probably not as common as the unregistered ones in many settings. We've already heard from Tim that the Morgan et al. Paper indicates that they often perform better in terms of patient satisfaction, but not always better in terms of technical quality. Their efficiency characteristics vary. They may be good targets for the kind of things Catherine was discussing, the sort of micro-level interventions. And there are systems-level interventions, like purchasing care from them, which could be done universally at a national level, but rarely has been. Not a lot of evidence about that. Finally, and this was a gap that we identified when we got to the end of the series, we hadn't really talked about this large-scale corporate commercial hospital sector at all, despite the fact that there has really been a lot of international investment going into that sector, particularly in the BRICS countries and Turkey. It appears that investment is premised on the notion of economic growth potential. In other words, it's an economic strategy rather than a health system strategy, and that very little analysis or evaluation has been done about the impact of investment in that sector on the health system. What literature there is mainly coming from India, and what it tells us is that the businesses are viable, people are making good money out of them, profit margins up to 100%, but they're clearly not going to be accessible to the vast majority of the population. There's just one example there of the annual cost of renal dialysis in one of these hospitals being 7 times per capita GDP. Not a very high percentage of the population can afford to spend 7 times per capita GDP. So then finally, just to conclude from the paper, but also from across the series, we have emphasised just the gaps in the evidence. It's really so many years into the discussion of these issues disappointing that better efforts to measure the things that need to be measured haven't been made. Some things are inherent difficulties, and some of Maureen's points were about some of the inherent difficulties of simply measuring the private sector, so there's maybe some things that not much can be done about. But there are also data sets that could be conceived of that have not been invested in that would clarify a lot in this area. It means that we tend to rely very heavily on DHS data, as we have done in several of the papers here, and because that focuses on children and rural healthcare, we may be getting a rather distorted picture of the role of the private sector from that. What can government do? I think the most thing that jumps out from the whole series is the main thing government can do is to provide a decent, subsidised service that is accessible to people. That regulates the worst excesses of the private sector. It leaves 2 possible roles for the private sector. One is that the private sector can be the deliverer of that subsidised basic accessible healthcare if they're purchased from to do that. And they can also provide additional beyond basic care for those that can afford to pay. The only alternative is to ban people from doing that, and as we saw, that's unlikely to be very effective. Government has roles as payers and direct providers, as purchasers, and as regulators, but not all governments are all that interested in pursuing the objective of universal health coverage through those mechanisms. And in those cases, probably the best that can be done is the kind of things that Catherine talked about in terms of small-scale interventions that try to improve the outcomes from that. Thank you.
Thanks very much indeed, Barbara. So we're doing up the time. Let me invite our 3 discussants to come up to the front, please. In fact, let me invite, I think we've got spaces for all of our speakers, so why don't you all come and sit up at the front. Now, unfortunately, or maybe fortunately, the camera only points here, which means that I'm going to ask our 3, so if you all sit down, then I'm going to ask our 3 discussants to present one after the other, but you have to stand here if people are going to see you. I don't know where people are watching you, but apparently somebody is watching you in somewhere. So we've got Jerry Bloom from the Institute of Development Studies, Simon Wright from Save the Children, and Lizzie Smith from the Department of International Development. So let's start off with Jerry, and then we'll go one after the other. Jerry.
Well, first, I'm just very pleased to have a chance to be here when you're launching this important special issue. A number of the authors and I have been involved in a series of symposia on the private sector that's been linked to the International Health Economics Association. And at the last one, a very, very senior health economist said, "I'm very confused. What do you mean by the private sector? You seem to be talking about so many different things." And I think he had hit on the core problem in the contributions of health economics and actually public health to the debate on the private sector. They were talking about so many different things and really weren't very clear about any of them. This is actually the biggest contribution to this series. It's finally situating the discussion about the private sector in the reality of the very different kinds of private providers there are and the very different contexts in which they're operating. And the first paper identified 5 different contexts, each context with wildly different options for government intervention. And that's just the start. So this is the key contribution. I found many of the policy suggestions very sensible. And of course, as a researcher, I endorse the call for producing more routine information and for research that generates lessons. But generates lessons from the many, many experiments always underway. The final paper emphasizes 2 things: that governments need to play a more effective role as steward of the use of public finance for health services and as regulator. And all of the papers have shown what an enormous investment in capacity building and institution building will be required in order to achieve that. But I thought I should share 2 additional thoughts. The first is, in the light of the complex and highly decentralized reality of many pluralist health systems, should governments also invest more efforts in ensuring the availability of relevant information to the public and to potential regulators, and to create fora for using those information to influence the health system? This is likely to be important, very important, if, as what Catherine highlighted, governments have limited capacity to influence performance at the moment, i.e. are issues about accountability much more important than we've heard so far. And second, how will the rapid development of low-cost diagnostic technologies and the plummeting cost of mobile phones and internet access affect the conclusions of these 4 papers? Will they open up new possibilities for ensuring access to competent advice and affordable health drug treatments? Or will they expose people to greater risks of exploitation? But a great start to what I expect will be a long debate.
Thank you. I'd like to first of all really congratulate the authors. This is a very useful series, and I think I'm not a researcher, so I'm not going to welcome the recommendation of more research. I'm going to say that actually we need to use this for advocacy and to challenge a lot of the very unsupported assertions about the importance of the private sector in global health systems. And it's very pervasive. Last week was a consultation meeting to establish this new WHO-hosted partnership called UHC 2030. There we started to say, how does the private sector fit into this? Nobody had any answer to it. We've gone through a period with the World Bank insisting on privatisation. We're not in that era now, but what we do have is still a lot of assertions that the private sector is the solution to global health. It comes from politicians who say, well, the private sector is very large, so we must work with it, without actually doing what these papers say, which is consider the impact on the whole of the health system. We also hear a lot, especially from donor governments, about we must look to the private sector for resources for health, and that because the public sector is limited, or donor money is limited. And actually that really needs exploring and challenging, because what on the whole they need is public sector money being used to borrow from the private sector to invest in the private sector, rather than that they give the impression that resources may be flowing from the private sector. And finally, I think the point Catherine did touch on it, but the antimicrobial resistance debate, this is kind of missing from this, the kind of role that an unregulated private sector is playing in building resistance to antibiotics. Because in so much of the world, buying half a course, sharing your course, buying what you can afford or doing without when you can't, is the reality. So the question that I think advocates need to be able to answer is there a role for the private sector in health? And there are colleagues of mine, including those at Oxfam, who might say no, there isn't. They would say that the private sector is intrinsically going to distort health priorities, is intrinsically going to make some of the wrong decisions around health, and of course that it extracts money from the health system. I think these papers show us that that kind of simplistic regulation of the health sector and the private sector isn't easy, and that the private sector is going to be part of the health system in nearly every country. So if it's inevitable, then the question that's posed by these papers is, what is its impact on universal health coverage? Is the private sector in a country helping? And so I think it's really useful. It gives us the typology, I think, that we've been given is very helpful, and I think we'll be able to use that. Those of us involved in some of the not-for-profit need to take some of these challenges as well about how do we consider our impact on universal health coverage, and the limitations of some of the private sector initiatives, often donor-supported, that has been shown in the paper. So the really important question, as I've said already, is to consider the impact of the private sector on universal health coverage. And we should be asking questions about where is it getting its staff from? Often from public training of staff, then going to work in the private sector, taking the majority of staff. On tax debates, you know, if we have a situation where the wealthy are able to buy high quality healthcare, they have a disincentive supporting a system where they pay fairly into some public pooling of healthcare to pay for funding to pay for healthcare for all. And so I think that a lesson that I'm going to use from this, and I hope the authors would think it's justified, is that greater investment in the public sector is the way to ensure that if there is a private sector, to what extent it's there, it improves in quality and it crowds out the low quality and dangerous private sector. A universal system must be universal. It must be universally paid into, and it should be universally available for others. Yes, for everyone. Yes, some people will buy extra quality and convenience of healthcare, but it shouldn't be at the expense of building a universal system. And the sentence that I think is in Barbara's paper and Cara's paper at the end says public investment must serve the public good. And I think that's a major challenge for DFID, for the World Bank, around the amount of investment that's been going into the for-profit private healthcare sector in countries with little evidence around what impact it's having on the public sector, on universal health coverage, and actually has been criticised for having little evidence for building a kind of inclusive economic growth in those countries either. So thank you very much for these papers, and we will make good use of them.
Thank you, everyone. And I'd just like to add my thanks to the Lancet and to London School for inviting DFID to this panel and for this launch and for this set of papers. And we really do welcome the serious academic study of this issue, both the attempt to pull together and make sense of the evidence that's out there, but also add to the evidence of the role of the private sector in low and middle income countries. So working with the private sector to improve health services in developing countries, particularly low and middle income countries, is a core part of the approach that we have in health to progress on the SDGs and to deliver the UK AIDS strategy. And this is actually also reflected in our forthcoming health system strengthening framework. And as I reflect, I just want to talk briefly about the context, about the findings that stood out for DFID in particular, and some of the implications and challenges for DFID and other donors working in this area. So first on the context, as others have said, this publication is very, very timely. It comes in the early months of a new era in international health as we make the shift from MDGs to SDGs. And the SDGs themselves put the spotlight on the health system that will deliver the Goal 3 targets. And so I think this series also helpfully then puts a wider boundary that encompasses the public and private that needs to be our starting point. And this set of papers really highlights this whole system approach, which is very welcome. Secondly, the things that stood out as we read it at DFID. And I want to focus on the interlinkages, the measurement issues, and something on the interventions. So on interlinkages, these papers very helpfully highlight the interlinkages between public and private sectors. They remind us that both public and private sectors can contribute to public health goals, and that countries progressing to universal health coverage need to consider the mixed economy of provision and finance and how they interact. These interlinkages are highly context-specific, and they really do owe a great deal to a country's history and politics. And maybe there could have been a little bit more of that in reflecting in some of the papers. And they are multidimensional. For example, sometimes we obviously have the same health workers both working simultaneously in both sectors, and those effects work in both directions. And I would have quite liked to see a little bit more about the differences in behaviour of the same individual health worker working in different settings, and there's quite a lot of interesting evidence on that. So a question is, how can we better understand these interlinkages and build them into our theories of change when working with the private sector? Secondly, on measurement, we really welcome the work to measure the scale and the characteristics of the private sector and to begin to get to grips with how the public sector shapes the private sector's market context. However, the papers, and especially paper 1, does reveal the paucity of relevant and timely data for measuring the scale and the scope of both sectors in ways that are meaningful. Data that is available is not comparable between countries. The poor timeliness of data, or the fact that some data sets are one-off, means that governments themselves don't have time series and trend data to make policy adjustments towards universal health coverage. So what can we do collectively to support countries' own monitoring of the whole system and adjust their policies in light of that? Thirdly, on interventions. These papers expand our understanding of the wider health systems implications of donors working with the private sector in developing countries to advance public health goals, and more specifically the SDGs. And a particular longer-term question for us is how, beyond a subsidised public sector, whether the private sector can be used to reach the very poorest with good quality services linked to prepaid and pooled financing through strategic purchasing. Is it feasible? Under what circumstances does this become a viable option? And how can we support that? Interestingly, I think we see in paper 3 that we have seen results to improve quality, coverage and targeting through social marketing, social franchising, accreditation, vouchers and contracting. However, as Dominic Montague and his colleagues' systematic review, which underpins paper 3 and is a really useful piece of work, reminds us that practice remains in advance of research and that fresh approaches are needed when measuring systems effects when working with the private sector, and that's a very useful reminder. In the near term, DFID's programmes generally sit in the encourage and subsidise space while working with the regulation that's already there, while developing the evidence base on meeting the needs of the poorest and how in the longer term we can support joining up with government, particularly in terms of oversight and financing. And what more can we be doing on this? And then lastly, thirdly, some early thoughts and implications and challenges for us and other donors. I think particularly the issue of system-wide impacts. There is a challenge to donors to where we draw the boundary in our understanding and monitoring of systems effects when working with the private sector. We've clearly been challenged not to limit it to the particular project or the particular part of the system. Secondly, more on politics. There was some reference to politics towards the end of paper 4, but I think it would be, we need to explore more about universal health coverage as a political slogan and how to harness the political momentum behind universal health coverage in a way that delivers equitable access to health services, especially for the poorest. And as Cara and Barbara say at the end of paper 4, how can we marry the political momentum with sound technical strategies? And finally, particularly for DFID, thoughts about fragile and conflict-affected states. So there was rather a paucity of coverage on these countries where we are actually going to have an increased focus in our bilateral programmes. And so we do need to think more about how we engage with the private sector in countries emerging from conflict or in protracted crises as they move along the development path beyond the well-trodden path of contracting. So thank you very much.
Thanks very much. Well, you've done a fantastic job. You're 10 minutes ahead of time. So now we have a full 30 minutes for discussion. And what I'd really like to do is to open it up to the audience to get your input. So please, who's going to start? Rob, and then Richard, and then back. We want you to be active too, not just the front. Rob, start.
Thanks
You
very
say
much.
who you are, Rob. Everybody knows you, I'm sure. You're a big supporter of the private sector, I know.
Well, Rob Yates from Chatham House. I mean, this is obviously a very controversial area, but just a suggestion for one conclusion. I just wondered the views of the panel on this. The benefit of splitting the debate between the public and private provision of services and the public and private financing of services. Most of the debate has been on the provision, and I think, you know, there it is obviously muddy and it's not clear at all. But I think when it comes to the financing, it is absolutely blindingly obvious now that compulsory public financing is better than private voluntary financing. We've been talking explicitly about moving away from out-of-pocket expenditure. But I think this has been this recognition as well that private voluntary insurance is also a useless way to reach universal health coverage. And the only two sort of countries that rely on it a great deal, the United States and South Africa, are trying to move away from it. I really think it would be great if the panel could sort of recognise that, you know, that is a sort of a clear conclusion, because I think there are still debates going on in countries that are struggling to make progress, like India, Pakistan, Nigeria, Indonesia, where there is still the suggestion that private voluntary insurance might be a sensible route. And I think it would be very useful, I'd be interested to hear your views on this, to sort of make that recommendation that public financing is better than private financing.
So we'll take a few comments from the audience and then come back to the panel. Richard.
Richard Wilford from Warwick. I understand that in low-income countries and low-medium-income countries like Kenya and India, there are sort of three problems of access for people. One is in the rural areas where quite a high proportion still live. One is in informal settlements or slums in urban areas where people don't want to go and work. And the other is people just not turning up to work in other places. So I was very interested in Barbara's graph of where she put the access on the, I think it was on the y-axis, and the proportion of money spent on the x-axis. And my question is, and it's practically very important, is to what extent is the proportion of GDP spent on health related to the GDP per capita in PPP of the country? Because if that top right hand is missing, but there's no correlation, then it's policy relevant in terms of, well, Tanzania, try and spend even more on healthcare. If, as I suspect, there's a correlation there, and that as countries become richer, they spend a higher proportion of their money on GDP, as I think China has done, then we need to be very careful about the policy corollary of that graph.
Okay, another question? Yes, please, at the back. And then we'll go.
I live in India, so I wish I could see more of these debates happening there, but I'm really happy to see it happening here. And well, I have a few observations, I have some questions, because I am based over there. I work with the school, but I'm based in India.
Just tell us your name.
Sorry?
Just tell us your name.
Meenakshi Gautam.
Very good.
And my area of interest has been the informal private health sector, about which very little is known in India, partly because there isn't much disaggregated data on the private sector, and partly because there is this hesitation to touch upon something that is so controversial and something so enormous that if it has to be faced, it's going to create lots of problems for the policymakers. Now, I'm really impressed by the data that you have used for the analysis over here in all of the presentations. And I'm not sure where exactly that comes from, because I find that DHS surveys and also the national surveys are just not disaggregating and allowing a real understanding of what the private sector constitutes in a country like India. We have the National Sample Survey, which comes up with this 70% of the population goes to the private sector. And everybody, of course, imagines that this private sector consists of these wonderful qualified private doctors who are there in every village and small town. But that is not true, and people have pointed that out. So the first thing is that needs to be understood. I find a lot of recommendations here for governments in low and middle income countries, but I also wonder what the larger global health community can do to put some international pressure. on a better understanding of this private sector and what we can do to universalize health coverage, either by creating better partnerships or by harnessing really those providers who are working with the people.
Very good. Thank you very much indeed. Over here, yes.
I think there's a set of countries around
Just
the world.
introduce yourself, sorry.
Carl Jackson from London School of Medicine. There's a set of countries around the world where the private, unqualified, low-quality sector is very large. I mean, India is probably a good example. And often the reaction to that is, well, if we have a better public sector, that will drive out these providers. But another way of looking at that is that sector is actually, it's a reflection of the complete inability of the government to deliver these public services. So I think the solution is not as simple as, oh well, the public sector needs to just step in and deliver high quality basic health services. And I think those set of countries are where the debate is actually the most difficult. For example, in India, do you try and improve the private sector where 80% of the population go to, or do you try and invest in a very poor and low capacity government sector to try and drive them out?
Okay, well, let's come back to the panel. Who'd like to kick off? No, why don't we start off with Rob's question first about the issue of public versus private financing of health systems. Who'd like to deal with that one? Barbara, go on.
I can start by saying I do agree, broadly speaking, with Rob's point. Public financing has better implications for most of the outcomes that we're concerned with than any form of private financing. We rather deliberately didn't visit those debates in this series because we feel they've been much more extensively debated than the issues of on the provision side. And in part because, as Maureen pointed out, there are much better data on the financing side than there are on the provision side, which have been endlessly analysed. I don't know whether Maureen wants to comment further on that.
I agree with that. And the only other thing I'd add maybe briefly is that one of the things we do know already is that there are interconnections between the form of private finance and the type of private sector that you get. And that forms of social and national insurance have different implications for the nature of the private sector. And developing, those understandings better would be useful for policy.
Okay, any other comments on Rob's point? No? Okay, so what about Richard's point, Richard Wilford's question about...
It's really too mean about our correlations. It's a complicated one to answer because, of course, you're right, broadly speaking, that there's an underlying correlation with GDP going on in this figure. Why we've quite deliberately just labelled them correlations and not made any claims about causation implicit in them. It isn't. I mean, we have examined it, and it isn't the whole story by any means. So there's even if you were to do something more multivariate and take GDP out of it, we would still see this correlation, but we didn't want to pretend we could do more with these data than we can by starting to use multivariate modelling because really they don't support it. And then just a related point from Minakshi's question about the nature of the data and where it comes from. There's a very good analysis in reference 9 in the paper, Hodgins and colleagues, that separates out where people are taking children when they get sick into categories which we could then use across multiple countries without having to go back to 100 DHS surveys ourselves. So we're very grateful to Hodgins and colleagues for doing that and enabling that.
I want to come to the question that we have from a colleague from India at the end, especially about the global health commitments. But Catherine, what about this question that Tim posed? Are we being a bit oversimplistic to think that we should be investing, if we invest in the public sector, that will help deal with this question of the private sector? I know it was, but I wanted to get you to answer it because Barbara's been very good about picking up the questions.
Well, I'm a pragmatist, so I'm always going to start from the position of what we have in the here and now. I mean, I firmly believe we need to be thinking where we want to go in the future, but I still remain interested in all of the interventions that deal with the poor quality private sector that we have, that actually points out exists and lots of people use. can you outcompete it in the long-term future with a better functioning public sector? I think it's going to depend on your political context. As you know, we were helpfully reminded that we need to be thinking about the political will in certain countries to address these problems. But it's also path dependent. Whether you can get the solidarity to do that depends on how far you let your high-end health sector go. And I think what we see in India is that it's gone. It's way gone. It's going to be incredibly difficult to get the solidarity, to get enough investment to deliver really good public health services, university at that level, because all the upper echelons of society are taking care elsewhere. So I think if another country, if you're talking about a Kenya or a Tanzania at the moment, they really need to be looking at more of these typologies and thinking, which one do I want to be in? Do I want to be in India, or do I want to be in Thailand, and actually making decisions at that stage? So I think make the change, think strategically before you let things get to such an extent that solidarity is really difficult.
Yeah, I mean, it's Liz's point about politics, isn't it? I think. So, Maureen.
Can I have one very quick point to that, which is it's not that nothing has ever improved in dodgy public sectors, and I wondered if my fellow author, Amos, who's here, would like to just add any points, because he was particularly interested in that issue when writing the paper.
Well, I think some of the graphs in paper 1 do show that when regulation and when changes have been made to the health system, there have been changes made to the proportion taken to different shops and lower standard providers. So there is evidence there that, slight evidence, is not greatest evidence, but I think that goes back to the point that there is a part that is taken. I think with regard to these typologies as well, I would like to make the point that those are not the only 5 typologies, that there are many, many more typologies than those that can be found and followed. And these are just groupings of this 3-dimensional space that was actually made. And without highlighting that, I think the whole idea about these 3 dimensions is something else.
Yeah, okay, very good. Any other reflections on this?
Yeah, I think
Barbara and then Tim.
don't hear often enough about the importance of a decent level of public expenditure on healthcare. Some countries can't do it, and then we look at how much they spend, and it's pathetic. And I just, if the 5% is a reasonable target for countries, it suggests that maybe they could do a bit more if they actually had enough resources.
So Tim and then Jerry.
Just going back to a couple of people were talking about urban areas and information. One reflection on that is that a lot of the surveys that we have at the moment, I think, are very focused on, still focused on rural areas. DHS is an example of that. And probably we don't know enough about what's happening with the private sector in the urban areas. And those systems will need to develop, because that's the majority of the population.
Yeah.
I mean, I just was going to reflect, because how that question is put, that either there should be investment in the public sector delivering services and creating good management systems. I mean, what we've described is the emergence of these complex systems with massive underinvestment in building institutions, and that's really what the paper showed, that there's no capacity to regulate, there's no capacity to do many things. What it says to me is there has to be much more investment in institutions with the capacity to either deliver or regulate. And I would come back to the comment I made, particularly because this is very political, much more investment in enabling people to hold health systems to account and to have the information and to have the platforms to start debating it. But otherwise, investing in a public sector that's going to deliver when all the rest is missing, I doubt is going to do.
Okay, let's come back to the audience for another round of ideas. Yes, please.
Suzanne McGregor at London School of Hygiene and Tropical Medicine. I just wanted to make a comment about the non-profit sector, which I think you said weren't quite sure of its role, and it links rather to the comment made over there that is there not a role for the non-profit sector that always would be in terms of filling gaps, experimenting and innovating, and in particular dealing with marginalised and stigmatised and excluded groups who will always be there. And so I just wondered if they are the not-profit sector should get squeezed out in this battle between public and private.
Very good, thanks. And oh, yes, please.
Yes, hello. I'm Christina Nielsen from the University of Southampton. So one of the discussions I've touched upon the issue where public and private sector interacts, and that is in relation to dual practice. And I would like to hear the panel's view on that, and a little bit more, maybe a little bit more on reflections on how to regulate dual practice, and how to sort of, because the problem is often that the people who are set to regulate the health system are also the people who are vested private interests. So it'd be good to hear something on that.
Good question. Other reflections or thoughts? Yes, please.
Thanks. Susan Murray from King's College London. I want to be slightly provocative, if you like, because I know that some of this panel do think about the things I'm going to say, but I'm a bit mystified. As in, it seems to be a bit of a gap between the title of this session on market property and public good and the focus that we've heard. Now, it may be something to do with 10-minute sessions, but it seems to me that one of the major, I mean, it does, I suppose, depends partly who the audience is, but it seems to be partly about advice and governance. But surely part of a really key issue is the move to see healthcare as an industry that contributes to economic growth, potentially does, particularly in countries that are emerging economies, middle income and so on. And I mean, in a way, I think Barbara was saying, oops, we didn't looking at the corporates, but what about advising governments on how to deal with aggressive healthcare industry behaviours across the corporates, and not only internally to countries. I mean, at the moment, Indian states subsidise the corporates with tax breaks, with land and so on. Should they be doing that? On the other hand, to deal with, I mean, the transnational industry. So to deal with UPA, for example, who's active in 192 countries in the world, are they to be welcomed with open arms, or are there risks involved in having these large transnational interests who also connect to financialization of the health sector? So their motivation is not to improve the public good in the health sector at all. That's not their obligation to whoever is helping. It seems to me those are huge issues that the healthcare sector is facing. And yes, it's particularly in the BRICS and so on, those in Turkey. But also, Indian corporate chains are now very interested in Africa because of the rising middle class and consumption of healthcare there. Very interested in managing hospitals within that continent and other ways of making money.
Yeah, no, that's good. That's a really great question, and I started off the discussion this morning by mentioning this commission that Barbara and I have been involved with. And as I said, one of the commissioners is one of the sponsors is South Africa. And we had one consultation at the World Health Assembly where Aaron Motsoaledi, the Minister of Health in South Africa, was present, and he was desperate to make the point that this colonization of the commercial health sector in South Africa is destroying his attempts, from his perspective, to establish a well-regulated public sector. The prices of the private sector are higher than, are extremely exploitative, and it's causing a real, and the health professionals are actually part of that collusion with a pretty rampant commercial sector that's challenging his efforts to establish universal health coverage. So this is a real problem. Why don't we begin with that question, because it is such an important practical policy question. Who'd like to begin with that? I mean, Barbara, Maureen?
Shall I say just one thing?
Please.
This paper that we wrote is based on big country studies done by individual specialists, and the Argentinian and South African examples do raise that issue very essentially. And the only place where we got kind of gone into the paper was from the Argentinian author. It's an enormous issue for the interconnection between social and economic inequality on the one hand, and health inequality on the other hand. There's a lot more to do, a lot more to say on it.
Yes, I do agree with you. The reason it's not here is because there's hardly any evidence about it. And these are papers that are trying to pull together the evidence. And so we got to the end of the process, and we wanted to draw from across the papers, which we planned as a kind of attempt to build a complete picture of the private sector. And it was a glaring gap in the way we'd sliced that up. It hadn't emerged as a theme of any of the papers. So we then went looking for what evidence we could find about it for this section, and it's really quite pathetic how little there is. And I think in particular it's pathetic when you consider the levels of global investment, particularly from the IFC, and it's proceeding on the basis of no research effort whatsoever. And I think it's, could probably tell you what evidence this is.
Let's pick up the question about the not-for-profit sector. Potential for innovation there? Yes, go on. Simon, why don't you go there?
Representative of the
yeah.
I mean, I think as you described it, is exactly the role that I think the not-for-profit NGO sector can play, including in OECD countries. You always have marginalised groups. You always need some sort of more flexible ways of delivery. That should be, in some ways, supported and come under a government stewarded health system. I think the problem is where it is allowing governments to escape their responsibilities. And that in lots of sub-Saharan African countries, having a strong, often the faith-based providers or NGOs providing healthcare, and the same argument could be made around donor support, basically reinforces to people that universal health coverage isn't their right, isn't something that their government should be expected to deliver, isn't something they need to vote for, it's something that they need to hope for and get from charitable sources. And that is what to actually change that relationship between people's expectations and their government's delivery, and especially how people vote, is crucial. And there's some good studies done by the World Bank that show that makes a difference towards building universal health coverage.
Any other reflections on the not-for-profit sector? Yes, please.
Yes, I'm entirely agree with what Simon says, and from a DFID perspective, I think we've traditionally supported non-government organisations in particular areas where there's stigma and discrimination to reach marginalised groups and also to reach remote populations. So we see they have a clear role in the whole system. I think the reflections of the papers were very helpful to disaggregate some of the very positive and sometimes less positive aspects of NGOs, so we can't be totally blind on that, so we have to be careful. I think the challenge we all face is how do we then, as donors, join up over the long term, link governments to supporting those NGOs, particularly in areas where they may be involved in, for example, supporting HIV, people living with HIV/AIDS who are drug users in environments where that's legally quite challenging. So yes, but how do we, in the longer term, move to this publicly financed support through NGOs?
Tim.
I think heterogeneity is as important as non-profits. The evidence is incredibly patchy. There is evidence that ethos makes up sometimes for lack of for lower skills and better performance, but there's also the opposite. And I suppose if you are going to contract, you've got to make sure that the providers adhere to the highest standards, the highest regulatory standards. So the regulation applies not only to the full.
Okay. Quick comment on, last 5 minutes, quick comment on dual practice regulation. Yes, Lizzie?
I think it's a really interesting question. It's one that I think goes to the heart of looking at the interaction between the public and private sector. A lot of dual practice is driven by very low salaries in the public sector. So, health workers are trying to live, they're trying to feed their families, they're trying to get by in as much as many others. So I think we need to really understand and analyse the labour markets in countries where we're seeing this and work with governments to make public sector salaries retain that talent. I think the issue is also true about getting the regulators being captured again because their salaries and the support structures and the environments in which they work are not conducive to carrying out that regulatory function. So I think we need to be really open-eyed on this and understand that in working with the private sector, we may also be working with people who are otherwise in the public sector. It's a huge challenge, but one over time which will be addressed by increasing spending.
And then we come to a question that was raised in the first round, and that was, okay, so what does the global health community do with this now? We don't want to just see the series published and put on a shelf, we want to do something with it. So where do we go next with this? What do you think the role of the broader global health community is in thinking about some of the lessons that we've been drawing out this morning? Who would like to pick that one up? Well, Jerry, I'm going to start with you, actually. I mean, global health, but let's include the wider development community.
Starting point is that we've been having debates and giving advice based on prejudice rather than evidence, and probably contributed to chaos. I think the way out is to invest not so much in whether governments are funded to deliver or to regulate, but it's clear that there just is not the capacity, or we've neglected the government building its capacity to steward or oversee the kind of complex system that's emerged. I think we have to see that it's long-term and that it is highly political, but that without investing in helping governments develop this capacity and then identifying good practices, no matter where they are, so that others can learn, I think it's going to be. I think if we try quick fixes on the basis of what was found by particularly Dominic, that there's very little capacity to regulate, we will make the wrong decisions.
Yeah, Simon, what do you think in terms of the world that you inhabit?
I think we can use these papers to, and in international fora should be challenging the promotion, the unevidenced promotion of the private sector, and especially things like tax breaks that KCL mentioned, and donor investment in the for-profit private healthcare sector, and instead reassert the importance of building the public sector and building public financing of public sector delivery, because that is what these papers say to me would improve things. Now, GDP and health outcomes isn't a simple correlation. The United States government expenditure on health per capita shows us that, but below a certain amount, and India is definitely below that amount, it's a no-brainer that you cannot be providing in any way decent healthcare if you're spending so little money out of the public budget on healthcare. India, a country that could do it, and India's outcomes reflect that. So we need to be just building up the consensus that 5% of GDP, in Barbara's Chatham House Working Group paper, $86 per capita, minimum, absolute minimum spend of governments, not total health expenditure, but government expenditure on healthcare, just to start being able to provide something that will look roughly like universal health coverage and will be benefiting the poorest.
Okay, very good. Last minute and a half. I'm going to give the floor to Lizzie and then to Barbara, just to give us something.
Yes, I think it's a really interesting question, and I'm very interested in the outcome of the commission you're working in. I think that there is this raised awareness, particularly through the Human Resources for Health strategy that WHO has produced and some of their background papers. I think we just need to expand our vision of what health markets are about. They're no longer national health markets or even local health markets. These are global markets. And I think we probably need to really appreciate the implications of that from the work that we do at the national level. And help countries and governments also really draw that boundary around the health system which encompasses that, and understand the linkages and the policy levers that they do have at their disposal, which I think we've just begun to touch on.
Thanks. Barbara, on behalf of your team of fantastic authors, you have the last word.
I think in my wildest dreams I'd like to think that we could have facilitated a more intelligent conversation than we've had to this point about these questions, and perhaps provided some language that will facilitate that in the typologies, for example, that help us to think about it. And the point that Catherine's made, that if we can see where we're trying to go more clearly, we can perhaps have better policies to get there. Because I think even that has not been very carefully articulated.
Thanks very much. Big thanks to our panel, big thanks to all the authors. Thanks to my colleague Stephanie Clark, who took this series through the Lancet peer review and everything. Thank you very much, Stephanie. And thanks to everybody for coming. Big round of applause too. And there is lunch in the pump handle bar, wherever that is.